Thanks, Julie. I think you've done a wonderful job of showing us some of the barriers to rolling out programs in low and middle income countries, but I think you've also shown us fantastically well that it can in fact be done. And I also live in a middle income country, and I have to believe that it can be done. So what I'm going to talk about a little bit today is what we need to do to achieve effective implementation of evidence-based programs in low and middle income countries. And because most of my work at the moment is focused on parenting programs, I'm going to use a lot of examples from that. But I'm hoping that what I have to say will give us some generic principles that will translate across different kinds of programs. And I just want to thank, this comes from a paper that I'm working on with Matt Sanders, Francis Gardner, Andy Dawes, and Chris Micton. So I just want to pay due acknowledgement to them because not all the ideas are my own. So what I'm talking about really is about programs, so not about the kind of complex stuff that Elizabeth Shaw was talking about, but the more defined kinds of programs. I am talking about a public health approach to programming, so not really the kinds of clinical program like an MST that's targeted at 1 or 2 people at a time, but programs that are either universal or targeted at large at-risk groups. So just keep that in your heads as I go through this. I'm going to talk about the fact that we need to know prevalence rates of targeted behaviors and risk and protective factors, about effective programs and having them available, about cost effectiveness, cultural relevance, and establishing effectiveness in the context of low and middle income countries, and what we do to try to tweak those so that we can work within the constraints that we face in such countries. So we do need to know the prevalence rates, the risk and protective factors for the targeted behaviors in a particular context. And for that, generally what we would do is a large-scale epidemiological study. And it's quite important to do this before you start developing your program or before you move your program into the new context. We know that these things vary across countries. So there's been some lovely work, for instance, done by Mark Bornstein and the UNICEF Mix study looking at cognitive and social emotional caregiving for children. Now we know that that kind of caregiving boosts intellectual skill and interpersonal skill in children, and that reduces the chances that such children are going to be aggressive. So it's quite important that we have that. But it varies very widely across countries. And of course, then it'd be no good going into a country where all the parents are getting that right, telling them they've got to do it better. That's a waste of money. You obviously want to target the low prevalence protective factors to try to boost them, or the high prevalence risk factors and try to reduce them. So we would be calling for large-scale epidemiological studies, but they are very expensive. So the good news is there are some shortcuts. First of all, there are some baseline studies in low and middle income countries as it stands that we've heard about the work of CDC and Jim and others in Tanzania and in other countries. The UBS Optimus Foundation is rolling out studies of child sexual maltreatment, 1 on each continent, and in Africa, that's in South Africa. I'm hoping we're going to be in the field in the next couple of months. So we've got some of those. But if they aren't possible, then you can use the established literature, because in many areas now, we have a good sense of what the risk and protective factors are. So for instance, we have the Lancet series on child development, which maps out very nicely what the likely risk and protective factors are to child development. We don't have to go in establishing that something is a risk or is a protective factor. We simply have to establish its prevalence in a given context. So that's what I'm advocating, is we use what we know already, and we can, in fact, cut costs by using the baseline study for a trial for that purpose, to try and identify those things. One of the other things, though, that is a gap is good, free, valid, reliable instruments. Now, there are a few. The Alabama Parenting Questionnaire, very well-designed instrument looking at the kinds of parenting that leads to aggression in children. It's a free download. But a lot of instruments that we need to use are proprietary, and that is a problem in low and middle income countries. And so this is a plea to those of us out there who like to design instruments. Please go ahead and do some that are simple and easy to use and can translate across contexts, and don't go the proprietary route. Make them free downloads for us, please. The next thing, and actually, I was at a meeting a little while ago in Australia, and with a whole bunch of folks from high-income countries who were talking about how it's a problem for them as well. So really, a lot of what I have to say applies not only in low and middle-income countries. Now, once you know what the risk and protective factors are, of course, you have to have an effective program available. And one of the problems is it takes time to build an evidence base for a particular program. Let me just sort of have an aside here. You're going to notice superscript throughout my slides. The five of us made a decision that we were going to show that we're drawing on an evidence base for everything I'm saying. And so right at the end of my slides, when you download them off the website, you'll find the references for what I'm talking about. This is one of Mary Rotherham Boris's, where she points out that it takes about 20 years to establish effectiveness. That's if you work very hard full-time on a program, because you're going to start out with your pilot test, then you're going to do your trial to establish efficacy, then you're going to replicate that and show that it is effective in another context, and then you're going to do a scale-up and show that you can get effectiveness, and that's the bit that takes 20 years. Now, I don't want to sit around for the next 20 years of my career messing around with one program when I live in a context that's got a lot of problems. We need to have stuff that works and stuff that works now. Again, we do have an evidence base. It comes from high-income countries. But what can we do about that? Well, we can draw on common principles from the existing evidence base. One of the things that we know, for instance, in the parenting field, is that programs that are based on social learning theory work well, and that they work well in a number of different contexts and with a number of different populations. So one of the places to start then is to look for programs that are based in social learning theory. And then there are really two approaches. Either you identify a local program that incorporates those principles and try to scale it up, or you take a program that's got an established evidence base elsewhere, you adapt it, and then you test it in the new context. I am going to say a word about testing. I don't want my country, and this is because I'm a taxpayer in South Africa, I don't want my country going down the route that many high-income countries have gone down, which is where we take programs and we throw money at them, and lo and behold, they don't work, and we carry on throwing money at them. So I am going to put a lot of emphasis on testing programs and on randomized controlled trials as the way to do that, because that really is our gold standard for showing that it's the program that made the difference. And really, there isn't an alternative. In a high-income country, you may have the resources to waste on ineffective programs. But in my context, if we're choosing to put money into a program, very often those resources then are not being put somewhere else. So if the program is ineffective, it's doubly costly. Not only have we wasted the money that was spent on the program, but we haven't been doing something else that may have been terrifically important. So I am fairly uncompromising on that one, but there's a fairly to that, as you'll see. I want to say a few words about cost effectiveness, because we all know that programs are more likely to be supported and sustained if they are cost effective. Much, much easier to sell to the public and much easier to sell to politicians, who, after all, are the ones ultimately who are going to pay the bills. We know something about cost effectiveness, not enough, but something from high-income countries. And the trouble is that the costs of programs, as they are calculated in high-income countries, often look prohibitive to low- and middle-income countries. So here's some context to that. We've been hearing a lot about the Nurse-Family Partnership, one of the most researched programs to prevent child maltreatment and later youth violence. The estimates in the US are about $8,000 to $9,000 per child. Now, in 2009, per capita health expenditure on average in low-income countries was $25 per head. In middle-income countries, it was $185 per head. $8,000 or $9,000, 25, 185. That's a very hard sell to the government of a low or middle income country. Triple P is a lot cheaper. I was at a Triple P conference this time last year. I met a number of other folks from low and middle income countries. I said, are your governments buying this stuff? They said, no, too expensive. I was surrounded by high income contexts where people were buying Triple P, rolling it out across countries, and paying academics to do the evaluation. And my government, I said at the beginning of my talk there, my government's priority is toilets and sanitation for people. And the day after I got home, the headline in the local tabloid was 10-year wait for toilet finally over. I'm never going to forget that. The thing is, we do also know that for every dollar that gets invested in the Nurse-Family Partnership in the US, you get about a $2.88 return. So it's nearly 3 times what you put in. The trouble is we don't really have any idea about how those cost structures translate when we get to low and middle income countries. It might be cheaper to roll the program out in low and middle income countries. But if you think about rolling out nurse-family partnership in a context where your Department of Social Services, which is tasked with dealing with child maltreatment, is underfunded, understaffed, and frankly not coping with the problem, we don't know if we're going to save more money by rolling out nurse-family partnership or save less money because the system wasn't doing anything about it in the first place. So we really need to put a lot of effort into understanding that and the economic analysis of these situations in low and middle income countries before we can really make any thoughtful recommendations to our politicians. Just a couple of related thoughts. One of the reasons why rollout costs might be lower is that we might have to use paraprofessionals. David Olds has done that lovely study in Denver showing that, in fact, paraprofessionals don't do as well as nurses, so he's adamant you have to have nurses. South Africa doesn't have enough nurses to deliver standard healthcare, so there's no way if we were to deliver a home visiting program, it would be with nurses. And in fact, there are a few home visiting programs, all done with paraprofessionals. We don't know yet the conditions under which paraprofessionals can do a good job. I'm guessing it has to do with training and with ongoing support and supervision, but we don't know what those look like. So there's a whole set of implementation science things we need to do to get that right. The other thing is that very often we might have to look at a different delivery method. We're talking typically about families living in quite abject poverty, and to get good child outcomes, you need a whole range of interventions. You need nutritional interventions for moms and for kids. You need social security, you need support for vulnerable caregivers, and then, yes, you need some parenting skills training with that. Usually those things are delivered in a package, but we don't, again, have good implementation science ways of understanding those packages, what would work optimally, and how even to measure the outcomes when it's being delivered in an integrated package. And that's something we really have to pay more attention to. Well, why do we need to ensure cultural relevance? And that's because poor ecological fit may mean loss of effectiveness, and that's what I've said to you I really don't want. And there are all kinds of reasons, and I think Julie's presentation picked up on some of those, but there are all kinds of reasons why programs might not translate well across contexts. You've got different languages, you've got different literacy levels, parents and those delivering program, you've got poverty, you've got different values, beliefs, family structures, child-rearing traditions, expectations about how children and parents should behave, the availability of trained staff, the acceptability of the program, health and social care delivery systems are going to be different. There might be some culturally specific risk and protective factors, and there's certainly going to be a different policy and institutional environment. So there are a whole set of reasons why programs might not translate particularly well. There is some hope, at least when it comes to parenting programs. There is some evidence that Francis Gardner has been looking at 11 randomized controlled trials done in low and middle income countries of evidence-based programs like PPP, Incredible Years, and parent-child interaction therapy. And she's found that a number of these programs work, and sometimes the effect sizes are very much bigger than they were in the original context, which is also something we don't understand particularly well, but we're glad to have it. And our sense is that these programs work because they're already designed to be sensitive, to be flexible, and to be collaborative. So they don't tell parents what to do. They work with parents to decide what would work for them in their context to achieve their goals as a family. So that's some good news. Now, it's not, unfortunately, all good news, because the evidence in this area is quite mixed. Carol Comfer talks about a Strengthening Families program which was culturally adapted, and it led to better recruitment and to retention in the program, which is exactly what you think would boost outcomes. Unfortunately, behavior didn't change. So cultural adaptation isn't a kind of fix-all, but it is something that one does have to think about. And there are many approaches to cultural adaptation, but there really are 4 key concerns to bear in mind. One is to balance fidelity to the original program with the cultural differences of the new setting. And to do that, you've got to have a program theory that very clearly specifies the underlying mechanisms for achieving those outcomes. So in your cultural adaptation, you would keep the mechanism, but you might change the delivery. As I've said before, we want rigorous evaluation of the adaptation, and while you're adapting things, you've got to take into account the implementation context, and very often that includes capacity to deliver the program. Now some words about establishing effectiveness. I think I've made the point about RCTs. They are expensive, and also if you think about the number of violence prevention programs that exist in every context across the world, the US as well as other low and middle income countries, it's really unrealistic to think about establishing effectiveness for every violence prevention program in every context. but we can't waste resources. So having said that RCTs are the gold standard, and I'm really strongly advocating for those, there are other designs. Quasi-experimental designs can still teach us a lot and are frequently cheaper, although not always. So when it comes to putting it all together, here's sort of the punchline of what I've been trying to say. You can cut costs a little on epidemiological work by using the baseline study and what we know already from high-income countries about risk and protective factors. We can draw out common principles from programs with established effectiveness and identify programs that incorporate those common principles. We need to boost our understanding of cost-effectiveness studies. We just really don't understand that well. We have to ensure cultural relevance, and even when you've done all of that, you still have to look at establishing effectiveness with the highest possible standard of evidence. Thanks very much.